Hello, my name is Rafiqul. I'm from Kyushu University Hospital, Japan. Today, my presentation topic is maternal and child healthcare by portable health clinic system using a triage protocol. This is a joint collaboration between Grameen Communications of Bangladesh and Kyushu University, Japan. Before I go to the detail on maternal and child healthcare, please allow me to introduce portable health clinic at the first. Portable health clinic is a telemedicine system that provides primary healthcare service with a special focus on non-communicable disease. What is the main cause of death in the country? Now, the first question is why we needed to start portable health clinic in Bangladesh. To understand that, I think it will be better to see the country's health profile. Bangladesh is an Asian developing country. About 30% of our population live in urban area and 70%, the majority people live in the rural area. In urban area, we have a good number of hospitals and doctors. In contrary, where the majority people live, we have very poor healthcare facility in the rural area. So in this situation, where there is insufficient hospital and clinic and lack of doctors, how can we provide a better healthcare service to the rural people? To solve this problem, we thought one solution could be telemedicine with the support of urban doctors. If we can connect the urban doctors to the village patient, at least we can provide some kind of support to them. But now the question comes, do you have enough doctor in the urban area to provide this telemedicine service to all this village community? Then we need to see the doctor-patient ratio of the country. We know the doctor-patient ratio is a very important factor for ensuring quality healthcare service. According to WHO, we need at least 12 doctors for every 10,000 people. But in case of Bangladesh, we have just 5 doctors compared to Japan, where they have 24 doctors. What does it mean? It means the patient seen by 24 doctors in Japan should be seen by 5 doctors in Bangladesh. In other words, the patient seen by 5 doctors in Japan should be seen by 1 doctor in Bangladesh. We can understand that this is not a good situation for providing better healthcare service. So we need to work to improve the doctor-patient ratio. How can we do that? The one simple solution is to increase the number of doctors. But we know this is not an easy task. It takes time. And the government is trying to increase the number of doctors, but it will take time to reach to the level of 12 from 5. So what could be the alternative way to increase the doctor-patient ratio? Another way could be to reduce the number of patients. If we can reduce the number of patients, we can have a better doctor-patient ratio. So how can we reduce the number of patients? The solution could be preventive healthcare, by introducing preventive healthcare. So this is not the situation of Bangladesh only. Actually, this is a common situation in any developing countries. So under this situation, you can see that there's 2 keywords. One is telemedicine and one is preventive healthcare. These needs are to be used to be cared for the better healthcare service in these unreached communities. So using these 2 keywords, we come up with a solution, what we call portable health clinic. So basically, it's a set of devices in a box, and it has connectivity, and it is operated by medical resources. So let's see a little detail of this system. The portable health clinic system consists of 4 components. The portable health clinic device box, as I showed before, the set of devices. It has internet connectivity. The second component is village health worker, those who operate this system. Third, we have an online server system so that we can share the data between patient and doctor and health worker. And fourth component is our call center, urban call center, where we have professional doctors there. So all these four components together work as portable health clinic. So how portable health clinic works in real field, let me show through a video. It's a small silent video. It shows that basically, as I mentioned, it's a set of devices in the portable health clinic box, and it is connected with internet, with our online system. So first, a patient needs to be registered with a unique barcode ID. Then the patient go through a health checkup. Health worker takes the vital information. We can take about 15 vital information using these devices. Those are important for the primary healthcare. Then this data are inserted to the application, and application has an AI system that can classify the patient in 4 categories. It identifies origin and rate, those who are severe patient, those who needs the doctor consultation, they are connected with the doctor, and the patient talks to the doctor, get the consultancy. Finally, doctor writes the prescription, and that prescription come out from the box because box has a printer. So the patient gets all support from consultancy, health checkup, and prescription altogether from this system. In portable health clinic, as I mentioned, we can take about 15 vital information, basic vital information in general. Now, let's come to the maternal child healthcare part. When we provide the healthcare service, primary healthcare service in the rural area, we find a huge demand from the village women about the maternal child healthcare service. And we can understand this is very natural because if you see the data, we have a high infant mortality rate, about 23, and we have high maternal mortality rate, what is about 173. If we compare with the developed countries, it's really very high. But if we look to the graph at the bottom, it shows a very good infant mortality rate growth in Bangladesh. The growth rate is declining very nicely. If I compare in 1971, when the country was independent, we had more than 150 as our infant mortality. But now it reduces to 23. So there is a good progress, but it's still it's very high. So if we like to go to a single digit, it shows that we will need another 25 years. So we can understand this is not a good situation. So we need to address this problem and do something to improve the situation first. Then we decided that one solution could be the continuum care of mother and baby, as promoted by WHO. WHO promote 4 antenatal care and 4 postnatal care, and we have added this in our MCS module of PHC. And if you look to the rural Bangladesh, the current situation is that government has some initiative to ensure continuum care. But the problem is we find that only 10% people go to the local community hospitals for continuum care because they feel there is not enough qualified doctors. In fact, villages, they don't have the doctor. These are operated by health workers. And also they have some awareness problem. Most of the people, they feel that they need antenatal care, they need the care when they need to go for delivery. But before and after, they are not serious about that time. So we feel that MCH module could be, MCH system of PHC could be a solution because in this system, we provide healthcare service by home delivery style. So patient don't need to come to the hospital, but the hospital goes to the patient. So, and the patient can talk to the specialist doctors using our telehealth system. To convert our MCS basic module to MCS module, we just need to add few new components. Basically, 2 are very important. One is heartbeat measurement Doppler device, and we have ultrasound image device. When the mother can listen the heartbeat of the baby by this Doppler, they feel very encouraged, they feel very happy, and they like this service because they feel it more touch with the baby. And when they can see their baby in their womb using the ultrasound image device, they are more excited. So they appreciate the service, they like the service. And this system is operated by village health worker, those who are working for the basic PHC. But in addition, we add traditional birth attendant, those who has a better access to the village women. They are also tagged with our service team, and they, together they can work. And we have the remote doctor from the city area. So service delivery process is the same. Our health worker visit the patient at home. They take the vital information, share with the doctor. Doctor can talk to the patients, with the serious patients, and provide the consultancy through a prescription, and prescription is delivered to the patient instantly. So the patient gets all service at their home. So they don't need to go to the hospital. That's why we call, but rather hospital goes to the patient's home. That's why we call it portable health clinic. And in this system, as I mentioned, that we use a triage protocol. Actually, there is 3 triage in this process. One triage protocol for ANC, triage protocol for PNC, and triage protocol for infant. And this triage is very much important because I mentioned that we have a limited number of doctors, qualified doctors. So we need to classify the patients. This triage process helps us to classify patients, serious patients, those who comes under orange and red. Only those patients are referred to the city doctors for the consultancy. But yellow and green patients are supported by the health workers. And this protocol was developed based on the Japanese protocol. Of course, we have adjusted this protocol with the local practice of Bangladesh, local situation of Bangladesh. If I show you the result, we can I can mention that we had about 175 antenatal care in last 1 year, and we find 8% red, 48% were orange. The main reason for red and orange are low hemoglobin, high blood sugar, and high blood pressure. In case of antenatal, we had found that 11% red, 37% orange, and the main cause are low hemoglobin, high blood sugar, high blood pressure, and body temperature. So in summary, the village where we provided this service, the population is 14,000. Out of them, we find 630 productivist women who participated in our program. And we have found out of them 134 people give birth of their babies under our program. And we didn't find any stillbirth. We didn't find any maternal mortality. So this is a good sign for us. Unfortunately, we find 2 infant deaths. But I like to ensure that these 2 deaths were not caused by the MCA service itself, but it was caused due to the COVID situation, current pandemic. These infants were referred to the hospital, but the hospital couldn't support them because they didn't have doctors during this COVID, they didn't have oxygen, and these were the main cause for the death. So I would say this is not related with the limitation of the MCA's service. And this is the real picture of the village, how our health worker provide services there. You can see that health worker, this time a male health worker, and the village birth attendant, female birth attendant is providing the service together. And they visit every homes, they take care of the mother, they take care of the baby. Finally, I would like to conclude here that the PHC MCA system empowers rural medical resources and uses them effectively with the combination of remote expert ops and gynecologists. The home delivery service can ensure maximum participation in continuum care and contribute to improve infant and mortality rate. And this is a very cost-effective and simple technology, and this is easy to replicate. So it can be copied and replicated in any part of the world where it needs. So that's all from my presentation. Thank you very much.